Okay, thank you for your patience. Cheryl, you can go ahead and get us started.
So we do have quorum, Katie? Okay, I can't see everybody on, I just see a few people. Okay, I see 4 of us anyway, but we must have 5. Okay. So welcome to our Finance and Revenue Committee supplemental meeting for January. Thank you all for attending. Glad we reached quorum because I know we have some things to talk about and important information to share. So we're going to start as usual with a tech check and then go right into the roll call. And I don't think I have a special question. I don't know if you do, Katie.
You'll omit it today just because you have a shorter time.
Okay.
That's that. But just a quick reminder with the tech check. I know we're all very familiar with it now, so I won't go over it. But I will remind those attending a part of the public, you aren't able to connect your camera or your audio because you aren't a committee member, but we're thankful that you are here and joining us. And then going forward, if you ever want to participate with the committee, you are able to do that through public comment. So please visit the Universal Health Plan Governance Board website to see how you can submit public comment, because I know that the committee does love to hear from you. So with that, we're just going to jump right into roll call, and just please let me know if you are present. Cheryl Ramirez.
Present.
Richard Gibson.
Present.
Jeff Goodman. Jeff, is your audio working, or maybe I just didn't hear it? Well, I know Jeff's here. Oh, okay. John Santa.
Present.
Thank you. Bethany Stairs.
Present.
Charlie Swanson.
Present.
Wonderful. Thank you. There you are, Jeff. And then Sam DuPont will not be with us this month. And then Chris Hogan is just not able to join us today, but they are still following along and members, of course. So with that, I will turn it back over to you, Cheryl.
Thanks, Katie. So first, we're going to review today's agenda. We're going to go through summary feedback from the previous meeting that we held in December. I'm going to give you a very brief update on a board policy change that you received the actual documentation of the policy change in your meeting packets. You probably read it already. And then we're going to try to wrap up the guiding document, the revenue principles and attributes. We've got some good feedback from some of you via email, and we'll have to go through that additional feedback. I'm not sure if it's in the draft or not. Then we'll jump into health expenditures discussion. Charlie's going to lead that discussion. I hope you know that. You've done a lot of work in between as usual. I really appreciate that, Charlie. And I couldn't begin to explain the materials that you submitted. And then we'll just go into reflections and plan the agenda for, I believe it's the 21st is our next meeting. So we'll want to plan for that. I also want to give you a couple messages from the board from our last board meeting when we provided updates on our committees. I just wanted to bring that back to you. We'll go into public comment. You've had 3 written public comments already provided, which were really thoughtful, and we'll have 1 oral comment today. So that's the agenda. So in terms of the summary feedback, it seemed to me that we had consensus that to combine the revenue principles and attributes into 1 guidance document. So you'll see that the draft document is a combination of those things with as many additions, revisions that we received by the time that they had to be posted. We're going to continue to work on health expenditures at each meeting, both the supplemental and the regular meetings. We'll schedule the supplemental meetings out for the next several months. I'm going to guess through June, but if we're done with health expenditures before that, that's fine too. And then we had a general consensus of the revenue sources, on the revenue sources that we're able to transition into Universal Health Plan. Okay. So here's an update on the board policy change. As I said, you received the written policy with your meeting packet, so I'm not going to read it to you. But the highlights to me are that it clarifies public meeting law, especially what it means to convene, and that includes serial electronic communication, and it also includes a board or committee member kind of acting as an intermediary and connecting communications together. It does articulate that communications among less than the quorum are allowed, but they're not official meetings. And we still have to have quorum to conduct supplemental meetings, so that we were holding our breath today, but we made it. And then it outlines the grievance process. And you may be aware that we're already involved in a grievance process as a board. So, so it's happening. So that's all I've got to say on that. I don't know, Morgan, if you want to add anything. Okay, we'll move on. So let's move on to the guiding document. We allotted an hour for this. I'm kind of hoping it doesn't really take an hour. My goal for today is that we approve this document and acknowledge that it's a living aspirational guidance document that we'll turn to when we're dealing with a particular topic that is in that document. So we'll go through, I don't know how we're going to do this. Are we going to actually look at the draft document, Morgan, or just go through the feedback?
I think it would be really helpful to, if Katie could pull it up for us so that we could see it and go through it. And apologies, I know there are a couple of committee members who did provide feedback that didn't get into this document. So that will be an opportunity to make sure that the committee members get a chance to share the feedback that's not reflected in this document.
And I don't remember, Morgan, if you're going to go through this, or do you want me to summarize?
I'm happy to go through it.
Yeah, if you don't mind, that'd be great. I know, just for one, I saw, when I went through my email, I saw Richard's comments and I jotted those down to make sure that we include those, but maybe we just hand it over to Richard to say those comments. And I don't remember if there were any others that didn't get put into the document. So I'll leave it to you. You probably know better than I do.
Great. Thanks, Cheryl. So what I tried to do is when there was feedback that was a specific edit to the document, I put it into the document, and and when there were suggestions or kind of thoughts, I put it in as a comment. And I tried to pull together the comments and discussion that happened at the meeting in December and the comments that were provided in writing since then. So you'll see the first comment is just their support, general support for combining these documents. So the revenue principles have been added into this. So there's no longer a separate slide or a separate document. I've removed the language about this going to the board because the conversation was that this would be that living aspirational document that can be used for guiding specific discussions that align with those discussions. Then the first piece of feedback we got was to add transparency and cross-checking are important. That had been something that I think the committee had talked about during the course of the health expenditures conversation, but it was added, suggested as a specific addition. So maybe before we go on, any concerns or feedback around this first section in general requirements? We'll take it kind of section by section. Any objection to any of the changes that have been made? Okay, let's move on. Katie, oh, thank you. So here you'll see this is a new section where those guiding revenue principles have been added into the document. The progressive, easy to understand, stable, those sections came from the slides that the committee had previously reviewed. And the first suggestion was around easy to understand. I think the thought was, the guiding principle is easy to understand, but there's also kind of, or at least a simple to use calculator could be provided, some way to make it easy for people to understand if the revenue streams aren't actually easy to understand, that there's some way to make it easier. Thank you. So then, these were additional principles that were added. And some of these are comments, I think just notes in, as this is being discussed. The first is that what the committee had talked about around needing more information on how to structure the income tax. And then you'll see new principles, limit. Oh, actually, I just moved these. These were in there's a second slide, additional potential principles for consideration. So where there seemed to be agreement, I moved it up. So limit movement, any revenue plan should be structured to limit migration. Well, I'm not going to read these. You can see them. These are the ones that were suggested. And then for the passage, there was conversation at the last meeting around if it was the role of this committee to kind of consider if the revenue plan should be likely to pass a statewide vote. So there was some conversation that should not be included as a principle. I left it here just so the committee could kind of decide whether or not they wanted to, but it's kind of it was a question mark for me, if you wanted to consider it or not.
Does anyone have thoughts about that particular principle and whether it should stay or go?
I don't have thoughts right now about that, but I do about some of the previous one, the last one, especially in right above that section. I just couldn't quite understand what it was saying, and I don't know if there's a misprint or I'm somehow misunderstanding it, but
that was on my list of questions too. I didn't understand that. Yeah.
okay.
I have to be honest, I don't remember where all of these, where each comment, each one came from. So if somebody remembers that was theirs, maybe they could explain it. And if not, if I just captured somebody's suggestion incorrectly, we can make the edits right now.
So I think that was, I mean, if I read the rest of it, it was my comment, I think. And so I'm just trying to figure out what it is that I had, but I mean, the essence of it is that we need to be aware of the federal tax expenditures. And the first few words just don't make sense. So you see, avoid economic hard of loss of.
Maybe hardship from the loss.
Yeah, that's probably it. That sounds good. Yeah.
Okay, are folks okay with that principle if we add those words to clarify and make sure that it's grammatically correct?
Well, then the end of the sentence, it needs editing too.
From that.
Yeah, I think the letter is just needing to be moved.
Okay, from that, but is connection the right word?
Oh. Mhm.
From it, well, it should be, well, the T and the that, yeah. I mean, it's a connection to the employer, so it's possible, but there might be a way to word it better. I think we might need to work on the wording a little bit, but let me just sort of see what I had sent initially, how it reads. If I can find that, but maybe we should go on while I'm trying to look for that. And
Great. It's a good, so Katie, let's not move on yet. What do folks think about the new principles, and what would you like to do with the passage principle? Is there any objection to, with, editing the avoid economic hardship, adding these new principles? Okay, I don't see any objection. Charlie, what was your, oh, I see a couple hands. Charlie.
Well, so if we were gonna go on, then I was gonna comment about the passage piece. But if not, I'll hold that comment.
Can you wait and just before we move
Yeah.
on to passage, what do
Yeah.
folks think about adding the other ones? John, I see your hand.
Well, I'm like Charlie. I thought you were asking for comments on the passage issue.
Okay, before we go to that, any objection to adding these new principles? Okay, no objection. Let's talk about the passage principle. Charlie.
I mean, so I do not think at this point in time, well, even probably almost ever, I'm not quite sure ever is the right word, that we should be concerned with that. We should get feedback from the public and from the rest of the governance board and perhaps from the communications committee on what the likelihood is and why there's some potential problems from it. But I don't think we should plan or design around that. I mean, it's way too, I think we're too early in the process to be thinking about that as a principle. I think maybe the board should maybe think about that in some way, or they should be thinking about how to make it more likely. And I would say also to get among the ways to make it more likely, I would think would be to put some sort of a outline of a plan out there and get feedback on it and have the public weigh in on it. So, but I don't think that we should have it as a principle.
Thanks, Charlie.
Yeah.
John?
Yeah, well, in short, I agree with Charlie's comments. Including it seems to suggest that the revenue plan should be put to a vote, but doesn't mention everything else involved in the proposal, which there's no question that voters would deserve to know something about everything else that's going on. And so to me, it seems odd that this one activity would be identified and isolated as more political or needing a vote. I wouldn't want to speculate on how best to implement this, but it seems pretty likely that at some point a vote on the substance of the proposal as a whole will occur one way or another. So I don't think it seems odd that one subcommittee would be focused on that, especially this one.
I agree with taking it out too.
Great. And then, so I will make note, we will not have the passage principle. Some of these other principles, there was discussion at the last meeting about not including them or they've been included up above. So broad-based was included in adding, multiple streams was included in adding. There was a comment that the comparison principle was actually duplicative of something that was later in the document. So that one was proposed to be removed. Does anybody have any concerns about or objection to deleting and not including the comparison principle? All right, seeing none. Moving on to healthcare expenditures. Oh, Charlie.
Yes, so I did have one more that I had sent in but had not been included that actually related to the revenue principles. So if I think it might be appropriate to go to that before we go to healthcare expenditure one.
Yeah, great. Thank you for catching that.
So what I would like to include as another principle is, to the extent possible, all categories of income by source should be treated equally. And the reason for the words to the extent possible is that Social Security benefits by the Oregon Constitution are not taxable, so they can't be treated equally compared to other sources of income. But I think everything else should be, and we might even need to think about how do we make up for the fact that Social Security income cannot be treated equally. So that's my suggestion and reasoning for it.
Any questions or thoughts about adding, to the extent possible, all categories of revenue should be considered equally?
Yeah, Charlie, can you elaborate on the case other than Social Security? I just want to make sure I understand your point there. What do you what does that language suggest a concern about?
Well, so there are a variety of ways that we can get revenue, and the ways that were considered most deeply, I guess, by the task force were with an income tax where all income is treated equally, and an employer payroll tax. And the employer payroll tax is really another tax on wage income. And so to me, that there needs to be some recognition of that in some way to make it so that wage income is not taxed more than investment income or other non-wage income. So I guess that's where my concern comes in, that we really would like it so that our healthcare tax does not privilege certain kinds of income over other sorts of income.
Should that be part of the statement so that people?
Yeah,
understand?
that's what I was gonna say. It seems like we should be more explicit because I didn't understand it either. I'm glad you explained it.
Same.
Yeah.
I appreciate the explanation and it makes a lot of sense, but maybe more explicitly.
So how about just adding something like, when I say all categories of income by source, whether it be wage income or non-wage income, should be treated equally? Does that help, or is that sufficient?
Yeah, that helps. What do you think, Richard?
In terms of treated equal, no, I think that's better. In terms of treated equally, I think what the implication is that it's a balance, so that when we say it's treated equally, that we consider the impact on of the wage and the non-wage. I mean, to say it's treated equally, we don't want to double tax wage and not tax another kind of income. But is that treating it equally or unequally?
Well, and I think to the extent possible allows for some unequal. I mean, because you have to balance the other principles, among them keeping it simple,
Yeah.
and so there's a variety of, I would say, somewhat conflicting things in these principles, and we have to. And another one that is going to be tough to put in there is to get rid of fiscal cliffs. And so to put all those together, we need to try to do that. And so it's a aspirational principle, I guess, is kind of what it is. So we want to be cognizant of trying to do the things that are in our principles, but we may not be able to meet all of them. And I would say we're almost surely not going to be able to meet all of them completely, because it's not going to be simple if we do some of the other things, for example.
Oh, okay, I don't want to belabor, but I think I get it now that you could say that the income is being treated equally because it's taxed. You could say that the payroll tax is being treated equally because it's being taxed. But if you lump income tax and payroll tax in the same category, you could say it's not overall that wage source of income is not being treated equally because it's being double taxed on both income tax and the payroll tax. So it's
Yeah, I can get into a much stronger, if we talk more about the details. Well, maybe I should say that right now. There are ways I think that you can get it to be a lot more equal. For example, you could count the payroll tax paid by an employer as contributing to the income tax that that needs to be paid by the individual, so that in that way you're getting around the double taxing. Now they're not going to be quite equal because the payroll tax might kick in a little bit different places, a little different amount of income than the income tax, but you can at least make an attempt to make it so that's really not double taxed. So I think that's an extraordinarily important thing, to not double tax wages.
Would it be helpful to, oh, sorry, John.
Well, I think this is an important discussion, but it is aspirational. I think, I especially think about Medicare, which I think will be a huge driver in terms of the need for revenue. And of course, most Medicare folks have no wage income at all, or very little. And so obviously, I think, to be fair, the Medicare folks will need to contribute in other ways than a wage-based tax. However, then you look at, well, everybody from infants, well, not infants, working teenagers to people who are 64 are contributing a wage-based tax for the future for Medicare. And so kind of figuring out what's a fair contribution throughout the lifespan for people to contribute to the, if you will, Oregon Medicare obligation will be interesting. It'll be tricky. The task force assumed that everyone would in Medicare would pay their Part B premium, that a condition of coverage would be they have to pay their Part B premium. Well, a significant number of people don't. And so will making them pay that be a tax? Where will that fall in terms of fairness? Because some of those people probably will deserve some subsidy or help in order to meet that requirement. So, there's just a lot of trickiness in here when you're trying to cover the whole span of the population. The existing system generates revenue in multiple different ways, especially when it comes to Medicare. So, I just underline, I think this is important principle, but underline the aspirational and tricky nature of it.
Thank you, John. All right, so I have, to the extent possible, all categories of revenue, including wage and non-wage, should be considered equally. Any objection to adding that principle?
Are we talking about revenue or are we talking about income?
I heard the suggestion was revenue.
It's a principle for revenue.
But adding wage and non-wage income to the
Right.
revenue principle. Yeah. Thank you
Yeah.
for that catch, Richard. Okay, any objections to the revenue principles kind of section? Or any other additions? All right, Katie, can we move on to health expenditures? Great, so we have two, and there was a suggestion to add long-term care should be broken out, other categories. We need to catch that grammar. There's an extra R. Other categories should be included but are less important. I'm getting the grammar checks in my notes. John.
Yeah, is by long-term care, does that mean the long-term care for all, or the current long-term care expenditures, which are primarily in Medicaid? Which is included?
Charlie, was this your suggestion? Do you want to answer
It
that?
was, yeah, it was. So I think that, again, this is trying to quantify healthcare expenditures. And, the beginning point is what currently happens. So that's among the things we want to quantify is what's currently happening. And then eventually we want to quantify, well, what would happen in the system that we would like to propose. And so I think we need to try to the extent possible, figure out what expenditures do go for long-term care currently. And yes, while their big chunk is Medicaid, it's hard to know in the state if the majority is Medicaid, but certainly nationally, it's a little bit less than half actually is Medicaid. There's quite a bit from other sources as well. And so yes, the intent is we try to quantify it when we can. And so it's kind of aspirational, but it would be nice to quantify because at this point, we don't really know whether the governance board is going to propose a system that includes long-term care as a covered benefit, or if they're going to do more what the task force did and not. So it'd be really nice to quantify it so we are ready for either possibility, and also so that we can say, either way, if it's not included as a covered benefit, then what of those expenditures do not need to be included in the plan as going forward. So anyway, it's a matter of trying to quantify it when we can. Now I know there's another principle up above that said we should also do the same thing for behavioral health and for personal health care, which I think is also a good thing to try to do. Or primary care, not personal health care, primary care. I mean, that actually right in the one above it, and for dental. So all those things are useful, but I think the only one that the governance board is like to consider not including as a covered benefit is long-term care. So the rest, I think we pretty much have to have them in there, but we don't necessarily have to be able to know how much they are. But if we can, we should try to do that. So and that's the essence of what it says.
Richard.
So in long-term care, my understanding is you have skilled nursing care, a lot of which can be paid for in the first few days by Medicare, skilled nursing care versus custodial care. And that much of the custodial care in the country is either paid for by Medicaid or it's paid out of pocket. That's my understanding. So I would ask anybody, but Charlie, is custodial care paid by families? Is that part of NHEA accounting?
Yes, it is. There's also some long-term care insurance, so private insurance pays a little bit as well. And there's also some, I think, that comes from charities of some kind, but yes, it is all part of the national health expenditure accounts.
out-of-pocket paid for by families for custodial care. Is that
Yeah.
part of the out-of-pocket that's up under personal
Ye-
health care?
Yes. Yes, it is. And in Oregon, most of what is paid for is actually in-home or community-based care and not in skilled nursing homes. I mean, Oregon actually has the highest fraction of long-term care that is not done in nursing homes of any state in the nation.
So we should endeavor to break out all of those at each of those sources, because some might be covered by the benefits committee and some might not be.
Yeah, yeah. So we should try to break it out.
Yeah.
Yes.
Cheryl.
Just want to note that the Plan Design Committee is grappling with this issue of long-term care. And also, I just wanted to note, kind of channeling one of my board members, that long-term care is not just for older adults. We're talking about the whole IDD system too, intellectual developmental disabilities system, and that is cradle to grave. So that, and there are no institutions for people with intellectual developmental disabilities. So that is all in-home care, or, you know, sometimes group homes, that type of thing.
Yeah, yeah. And so among the sources that I'm looking at is Oregon Health Authority budgets, and also the Department of, well, actually for long-term care, it's all in Department of Health and Human Services. Or not even Department of Human Services, not Health and Human, just Department of Human Services budget. And so if I recall, the IDD portion of long-term care is about the same as the age and people with disabilities portion.
Yeah, we've
So
got
it's,
it.
it's
Mhm.
it's pretty similar in size. So yes, a lot of it is what you're saying. It's
Yeah.
cradle to grave.
Mhm.
And I will make the attempt to use that OHA budget information, or I shouldn't say OHA, DHS budget information as well, as I'm moving forward with the breakdown, which we'll talk about later.
Good discussion. So, Charlie's proposed, long-term care should be broken out. Other categories should be included, but are less important. Does anybody have any objection with adding that addition? See a thumbs up? Thumbs up, great. Any objections to the healthcare expenditure section? Great, let's move to healthcare revenue. There were no suggestions to this section. Did anybody have any additional suggestions that weren't captured in this document? Great, let's move on to new plan development. We've got a suggestion here to the last, not the last one, to 13. Estimates of savings that depend on a payment method should be clearly designated. The place in the funding stream at which the savings are expected should be stated. Any questions or discussions about this edition?
Just add a B there for global budget.
I'm sorry, say that again?
Oh, just add a B in front of budget in the in the fourth line is.
Thank you. Any objections to that addition? Okay, and I think that that's the last change in the document. Were there any other additions, Richard or Charlie, that you wanted to make that didn't get in this document?
We've covered them all that I had. Thank you.
Same here.
Wonderful. Any objections to this document as edited and discussed today?
Hey, Morgan, just a process question. Are we going to formally vote to approve or just check that we have consensus that we're good to go and we're done for now?
Yeah, I think that would be up to you, but you know, what you talked about was that this would be a guiding document for the committee. And so I think that you could do that by consensus. You could absolutely take a vote if you want, but I think either way, because it'll be an internal document for this committee
Mhm.
and aspirational and
Yeah.
providing discussion questions. And I think it's up to you how you want to treat it.
Okay, well, I'm fine with just taking kind of a more informal consensus. Oh, and there's Jeff. Maybe he has something to say about that. Go ahead, Jeff.
So, it's an internal document. We can do informal consensus. I just want to know how soon after we get this done, will it go up on to our website so it can be accessed by anybody?
I will work on, I was making changes in a Word document as you were all talking. So after, I'm hoping later today.
That'll be great.
And so Morgan, do you want the committee to look over one more time just in terms of proofreading the edits, or how will we work that out?
That is up to you. If you would like to do that, I was thinking that staff would take on that role.
Okay,
And
all
we
right.
could just, I was live editing and catching the B and budget and
Yeah, that
extra
kind of stuff.
words.
Okay.
But I'm happy if you all want to do that too.
No, well, I'll leave it up to you guys. If someone wants to volunteer to do one final proofread, that's fine, but otherwise I'll just leave it up to staff as far as I'm concerned.
Do we need to come back about the one about the tax effect of removing healthcare expenditure from employers? I think Charlie, we're still gonna come back to that. Isn't that right? It was at the bottom of the first section. I think next page. Yeah, that one, avoid economic hardship. First, I want to get the concept right, and then we'll get the words right. I think the concept is that or I'm asking Charlie, is the concept here that when employers get a expense deduction for providing health care to their employees, that is in sense federal support of healthcare? Is that the concept that we're going after here?
Yeah, and it's more than just what the employers put in. If the employees put it in through their employer's plan, then that's also
Exempt.
a tax deduction, a tax expenditure from the federal government. And so if for example, we did not have an employer payroll tax and we decided to go purely with a personal income tax, or well, I guess basically we decided not to do an employer payroll tax, then the money that is saved would likely, at least a bunch of it hopefully, would go to employees, and then it would be federally taxed. And it would also not only just the income tax, federal income tax, but also the FICA tax.
Okay.
And all of that money would leave Oregon because it'd go to the federal government. And so that is essentially taking money out of Oregon's economy. And it would be better to the extent possible to keep it here and use it for healthcare if we can. So.
Okay, great. I understand the concept. Now can we say that in 25 words?
Yeah. And I will look at what I sent. So I guess I will volunteer to look at what or to send something to Morgan after this meeting. And I guess if anybody else wanted, I could maybe a few of us can look at it and make sure that it makes sense according to what we've discussed today. Is that reasonable? At least I will send something to Morgan after the meeting because I don't think I can do it right now.
Now, if you all are comfortable with a general agreement about the concept that's been discussed here and allowing the wordsmithing to happen offline, I'm happy to work with Charlie on doing that.
Great. It's fine with me.
Thanks for catching that.
All right. Well, so I'm going to say we're good on this document. I'm glad that we even got it done. Oh, John, maybe you have the last word on this.
Well, just, you know, my guess is there will be a variety of tax implications for this. Again, when it comes to Medicare, I believe that when your Part B premium is considered, it's not a tax, it's considered a healthcare cost. And so to the degree your income allows it, you can deduct it. Would other things that we do in terms of asking individuals for contributions be considered a tax or be considered a healthcare cost? You know, would if the employer paid the payroll tax as the task force recommended, my guess is that would be not taxed as, you know, a health expense to the employer. It would come off their bottom line, you know. So I'm just, as I listen, I think Charlie's on a really important issue, but you should start to anticipate, Morgan, that a tax expert may need to help Charlie and any of us who try to figure this out.
Okay, that's a really good point, and I do hope we get those consultants in, and maybe, I don't know if there's any update on that, maybe we can save that till the end, but looking forward to that help. So with that, I believe it looks like we have consensus that we're supportive of this guidance document with the edits, and a couple of you are going to work on that one particular principle. And then we'll, again, it's a living document. We may need to change it, you know, going down the road, but we'll refer to it often as we work through all of these different topics and issues. So with that, we'll move on to healthcare expenditures. I'm really glad that we have a bit more time for that. And I'm just going to really hand this over to Charlie to lead this discussion.
Great, thanks, Cheryl. So you can go to the next slide and we'll start looking at it. So the National Health Expenditure Accounts has sort of three categories of overall expenditures. One is total expenditures, and that basically includes everything that they think is related to healthcare. And then they have what's called health consumption expenditures, and the thing that's left out, you know, well, of total that to make it health consumption expenditures is investments. So it does, health consumption expenditures don't include investments, which are both research, so research by private entities that or public entities, and also it does not include capital expenditures. They're on facilities or equipment. Major capital expenditures, I should say. But we're not concerned really with the health consumption expenditures. So we're going to be concerned primarily with total and personal health care. And personal health care is total expenditures with the research and capital expenditures removed, and also with the public health removed, and also with the administrative costs removed, administrative costs of the sponsors. So that is the net cost of private health insurance, but also the cost of administering government programs. So essentially, the personal health care is the word that National Health Expenditure Accounts uses for most of what we think is healthcare expenditures, minus the insurance and insurer overhead, whether it be a government insurance or private insurance. So both numbers are important. And I have done a couple things here. In the columns labeled Oregon imputed by population, I basically said, what if we just look at Oregon's fraction of the national population and take that same fraction of national health expenditures? What values do we get? So that's what's listed in those, I guess, essentially the fourth and fifth columns under Oregon imputed by population. The yellow highlighted column starts with things, some information that I had sent earlier to the committee, and those are projections of personal health care. And I've actually removed the VA, and the next slide will sort of show why I've removed that from these. And so those yellow values are the values that I got just by, well, I did actually 6 different ways of trying to project what Oregon expenditures were. And then the best values highlighted in green are ones that I'm pretty confident about. And these all at this point come from MBES reports and include things for both Medicare, Medicaid, and CHIP. And it's broken out into federal and state and local sources. And I have another slide which I will show that I break that out more, so there's more details that are in the spreadsheet that was sent out, I think, to everybody. So I've also done some work since I sent this in, comparing the Medicaid numbers from MBES to both the cost growth trend data and the consolidated financials from CCOs. And I will send that in, but they compare very well. Essentially, what the reason that the numbers don't look the same for the cost growth is because there's a couple major categories that have been left out of cost growth, and one of them is long-term services and supports, and another is the overhead in the state program. So the state overhead, which is reported in MBES reports. So I'll go to the next slide. So this is the rest of the list of things that are included in national health expenditures. And so down towards the bottom, you'll see public health activity, which is not part of personal health care, and also structures and equipment, which is not part of personal health care, both of which I think we want to include until we find out there's a reason that we don't need to include it. But at this point, I think we want to make sure that we're accounting for it to the extent we can. And I do note there's for Indian Health Services, the numbers were not imputed from national population, but from Oregon's fraction of tribal populations. So they are, because Oregon has a larger fraction of members of tribes than the nation does, these are a bit higher than what they would just be from the population. So, and you can see that so far I don't have best values for the rest of it, and so that's kind of what I'm working on, and I'm sort of proceeding through each one. I actually do have some pretty good numbers for other private revenues that I've gotten since I sent this in. So, and I will be sharing that as I make progress on getting better numbers. So we can go to the next slide. So this next slide just gives some definitions from the NHEA National Health Expenditure Account methodology of the things that might not be so familiar to us, but are monies that we want to try to quantify to the extent possible. And I will say that for other private revenues, it's become pretty clear from Oregon data and actually federal data as well that most of the other private revenues is non-patient revenue, which we can find information for. So, and if on the spreadsheet, all these things are on one spreadsheet, and I think I will continue to make it so that all these things fit together nicely on a spreadsheet, and they just can't fit on slides very nicely. So, so we can go to the next slide. So this is more detail on Medicaid and CHIP. And again, all of this is from MBS reports, which is which is a report submitted by the Oregon Health Authority to the federal government, to CMS. And so this information essentially comes from both the Oregon Health Authority data and Department of Human Services data. So I break down the federal share and the state share. And for the state share, I've actually used Oregon Health Authority and DHS budget information to try to figure out how much comes from the general fund and how much comes from other state sources. So one of the things to note is that the numbers for 2019, which I can compare to Optimus, are exactly the same because Optimus used the same source. So the numbers that the Medicaid 99.36 million spent in 2019 and the 448 million spent on CHIP in 2019 are exactly the same numbers as what was in the Optimus report. But I have a range of years that I want to continue to keep so that we have at least some potential way of projecting into the future. It's going to be very uncertain, but at least we have a bit more than just 1 year's worth of numbers. Actually in the spreadsheet itself, there's quite a bit more detail than what's here. Again, just in case we might need that information. And you can go to the next slide, please. Oh, that might be it. Okay, that's it. I guess any questions, and we can go back to the slides if you have particular questions.
Carol?
Charlie, I have just one super basic question because I want to make sure I'm tracking. Could you explain again what personal health care includes? Because I'm not sure I got that down, as opposed to the total health care
Okay,
expenditure.
so it's more what it doesn't include, I guess. Total healthcare expenditures is an estimate of all of the things that are spent on healthcare.
Uh-huh.
If you leave out public health and you leave out investments, which is basically research and structures and equipment, and you leave out the administrative costs of private insurers and government health programs, then you get personal health care expenditures. So personal health care expenditures leaves out the insurer administrative costs, and with that, independent of whether it's the insurer is a private health insurer or a government program, and it leaves out public health and it leaves out structures, research and structures and equipment.
I think it'd be worth putting that in some sort of footnote, just so everyone who reads this understands what that
Okay,
includes,
okay,
does not
I will do that.
We'll make a slide for that. Very important.
Mhm.
Yeah, actually, it might be sort of on the bottom of the spreadsheet, but yes, it could be in a slide as well. And among the things that it also leaves out for personal health care is when there is a private entity, a private insurer between a public program and the provider, for example, Medicare Advantage or the Medicaid managed care organizations, which are called CCOs in Oregon. It also makes the attempt to, if in estimating private healthcare, to leave out the those administrative costs as well, because those are essentially insurance company administrative costs and not provider administrative costs. So the administrative cost of providers is part of the personal health care, though. So all the administrative costs in a doctor's office or in a hospital are part of the personal health care expenditures. So yeah, I will include information on what personal health care means.
Yeah, that'd be really helpful for me. So before we go on to like next steps, what's next to do with this? Do others have questions or comments about the data here?
Yeah, what Charlie didn't talk about, but was a huge part of his effort, was that we're mixing federal fiscal year with an Oregon biennium in terms of a lot of the accounting. And so you had to take a quarter of the previous year and then 18 months of the following year in order to match up. It's more detailed than that, but you can see that the challenges that he had to go through to get to this was mixing a biennium, which goes July to June, with a federal fiscal year, which goes, of course, October to September. So a lot of work.
Yes, I am familiar with that. That is really difficult.
I will also add that the actual national health expenditures are calendar years to make it even more complicated.
Fun.
Yeah.
So we had talked about this idea of double count versus double check. So will you take this data and compare to other sources of information? Is that maybe a next step? I don't know. I'm just asking.
So I have done that in detail for Medicaid, and I will be doing that, whenever I can. Yes. So I will be doing that. But yes, for Medicaid, I have done that, and I can share that. Well, I can share it soon because I have that portion done, and it's in the same spreadsheet and on another worksheet where I make that comparison. So yes, I will continue to do that.
Yeah, great. Richard.
I foresee using this spreadsheet as sort of the base budget for healthcare expenditure in Oregon. And it can always be refined. We can always put in subcategories, like the subcategories of long-term care support services, both facility and home-based, about how much is out of pocket and how much is different kinds of insurance and that sort of thing. But the other thing that I think might be helpful for the group is, over time, we'll have a column to the right of the columns here that Charlie's got on his slide that says, is this particular line item included in our single payer plan, or is it not? And again, we didn't want to do that right now because we didn't want to make suggestions for the committee that this should or should not be included in single payer plan. But as people come and say, well, what about this? We can go back to the spreadsheet, go down the line and say, oh yeah, we're not including VA expenditures in part of the single payer plan because that will likely remain outside of the single payer. But we might get down to some aspect of long-term care, or we might get down to some aspect of federal employees, TRICARE, or Department of Defense, where it does, and then we'll move that check mark from not included in the single payer plan to included in the single payer plan. So I thought this was a great place to start that accounting and keep a column of what's in and what's out of the proposal for the long-term, for the Oregon health budget.
Yes, definitely. Oh, and I have another question, but I'll first go to Charlie.
And there are things that have come up that relate to the potential double counting question that I would like to bring up as a potential question to ask. I guess both. I have I think a question probably for the Oregon Health Authority and another one for DHS. So there are items listed as ADM, or administrative costs, state administrative costs, in the MBS reports. And there are a variety of things in the Oregon Health Authority budget, which look like they could be items that would have been reported on the IRS or CMS form 64, I guess it would be. So for the MBS reports, that could have been reported as administrative costs by OHA for Medicaid, but it's not clear whether they were. And so there's like I have some specific questions related to, are these reported as administrative costs on MBS reports, or are these additional expenditures within the Oregon Health Authority that maybe should be thought about as a health expenditure? So I guess I have some questions related to that. And there's another question for DHS about vocational rehabilitation. So you can see that vocational rehabilitation is in the National Health Expenditures report, but the number from DHS for vocational rehabilitation is a lot greater than the imputed value. And so a question would be, would most of that be considered healthcare, or is it something else that is appropriately not considered healthcare? Just to make a check with the NHEA reports. So I guess there's some specific questions that I have.
Just real quick, in terms of what you included here, it made me wonder about something, and it's something that also the Plan Design Committee is discussing. Do these expenditures include institutional care, that is the Oregon State Hospital, Department of Corrections, healthcare, and does it include healthcare for inmates, jail inmates? Because I know this is something that they're discussing, and of course, as you know, we have a waiver that will cover some services for jail inmates, but the state hospital is still largely general funds. And when I look at the general assistance here, that's certainly not a large enough number for Oregon. So wondering if you included those.
I do not know the answer. That's one of the questions I'm trying to figure out within the National Health Expenditure Accounts is, do they include something like the Department of Corrections and the state hospital? I intend to include it on further analysis, the numbers that we can find from either the budget or from the cost growth trend data. But I don't know whether it's included in the NHA reports. I think it might be under hospitals, because the number that is the estimate. So CMS provides state level data for up through 2020. So, you know, if we want more recent data, we can't get it from CMS state level data. But up through 2020, if I compare the numbers that they indicate for hospitals in Oregon, it's larger than what's reported on OHA reports, which tracks all of the private hospitals in Oregon. But it does, that report does not include the VA and doesn't include the state hospital. And so I'm thinking that maybe the numbers of NHEA are larger because they do include those, but I do not know the answer to that. I'm trying to find that out.
Well, and as you know, the state hospital and DOC are going to have very little Medicaid revenue, very little.
Yeah, and so, you know, this is this includes everything at this point. Yeah, so it's not just Medicaid, but yes.
Yes, thank you. Oh, go ahead, Richard.
So I queried a contact in OHA about the breakdown of medical expenses, were they part of admin and all, and I was referred to Jessica Marino and Danielle Ross, who are supporting this committee. And then the question came up, I was asking it, but since I'm just essentially a member of the public, it would have to go through a public records request to get to the analyst that knows the answer to the questions that Charlie just talked about. or we could have the committee say that they would like the information. And I've got it all queued up here in my email and on a Word document here on my screen. But anyway, the point is, we can go through a public records request, but it's probably more efficient to have the committee ask for these extra points. But we haven't done that yet in this committee, so I'm sorry I didn't warn you about this first, Cheryl. I just got back from Jessica a message yesterday about going through the whole public records request. So
Okay, that's fine.
how should we handle this?
Well, I would defer to Morgan on that process.
Okay.
I'm not really sure. I mean, my personal opinion is I'd rather not do a public records request, go through the committee, but I'd like to check with Morgan on that.
Yeah, I think this is one of the things we talked about at one of the very first meetings. I think we need to make sure that all of the requests for information are coming from the committee and not just one member, because I think that could really quickly overwhelm the number of staff that we have. So I think the idea was that there would be kind of an endorsement from the committee that this is the information that the committee needs, and then we would be figuring out who to work with to get that information. So that's kind of why we want it to come from the committee. And, you know, we do have analysts who are supporting it, want to make sure that we're like deploying them when it's been kind of like been discussed and kind of the committee's given that nod that this is the next information that we need. So it would be up to the committee. So the answer to your question, Richard, is it would be up to the committee to say, like, here are the 2 or 3 things that we need to help support the progress of this work.
So
I would take a draft, or if you could share that email, Richard, so that could come from the committee. And I'm certainly a relief to me that we don't have to do a public records request.
Okay. Okay, so
you could probably share it, Richard.
asking, do we need to vote on it, or do we need a consensus that the committee supports asking for these 3 particular questions? 2 to OHA and 1 to Department of Human Services.
And just to be clear, we don't have anybody on our team that works for DHS. So I don't know. So it would be a different process for DHS. We don't have an analyst who's working on this committee who works for DHS. So we would be able to handle the OHA ones.
Yeah, but could they ask someone in DHS for the information?
Yeah, and yes. And I'm just saying that we don't have, it won't be like working on the answer.
Or could we ask someone from DHS as a committee? Is that okay? I mean, I just have to identify who that would be, but I think I can find out.
Yeah, and I don't think this is just a one-time thing. This is just the first 3 that we can work with. And again,
well, we've got to start with that, I suppose. So
I mean, do we need to look at the particular questions or within the committee?
I think so. So we can get consensus.
So,
and
Richard, I think you can share.
Vote either. I mean, it's just like everything else, right, Morgan? I mean,
yep.
Do you want me to share my screen now, or do you want me to send you an email and we can pick it up later? Send you an email and we can pick it up later in the meeting. What works best for you?
You have the ability to share your screen if you would like to, Richard. I think that'd be easiest.
Yeah, let's just get it done.
All right. So here's the first one. It's the OHA information request. Can you see that?
Make it bigger.
Yeah. Okay.
So this is derived from Charlie's spreadsheet. And what we're talking about here is line 4. The question is on line 4, what is the source of the 730 million of other funds? So these are, we have federal funds, and then these 3 come from Oregon State, the general fund, Oregon provider assessments that help attract more money for Medicaid, but then there's Oregon other. And so it's not a huge amount. You can see it's about a 20th of the total amount, but we were just asking, what's the source of the other funds? Again, it may be significant, it may not be, but we thought we'd ask. So that's one of them.
Just real quick, I wonder if OHA staff will know the source of this data. I wonder if you could tell them that, just so they're on the same page with those numbers.
Yeah, I mean, the source of that data is essentially OHA budget information, but
Okay, so
it's
that just comes
but
from.
it's broken, their budget, again, the budget information is for biennium, and so this is broken out
Right.
to a year. And so we could share the details of that, but
Yeah, I
it
think we
it
need
probably doesn't
to.
matter, actually, because it's just whether it's biennium or year, they should know the answer to that.
Yeah, we need to note that though, so that they're not wondering how we came up with that. I think.
The second one, Charlie came up with this from the Health Systems Division budgeting, that they show $140 million running the Oregon Health Systems Division. And the question is this considered an administrative expense of Oregon Medicaid, or is this separate? So again, this is an area where we don't want to double count. We're just double checking.
Right.
Again, it's not a huge amount of money in the big picture. 140 million, obviously a lot of money, but so we just wanted to ask, is this part of the admin expense of the Oregon Health Plan?
Okay.
Okay, and then the other, I'm going to stop sharing this. I just have one more, and then I'm done. Which is the request for the Department of Health, Department of Human Services. I'll enlarge it here. So this is again from Charlie's spreadsheet that we just had up: vocational rehab, federal and state. So vocational rehab from work. When I looked it up, this really comes from the Federal Department of Education, not from CMS. And so we were just asking, is this VR budget, it's managed by the Department of Human Services. We just wanted to find out, is any part of this vocational rehab already included in other aspects of Oregon healthcare, or is it separate? Does it come from CMS, or does it come from Department of Education? The federal part does, but anyway, you can see the numbers are very small, but we're just trying to do a good job here.
I would actually like to expand this question a little bit, because the budget information for the DHS, which is listed as vocational rehabilitation basic services, is much larger than this. And so I guess the further question is all of that reasonably related to healthcare, or is it something else?
Okay, well, if you could just work on that question, we can, I mean, my opinion is we would start with the voc rehab director, because that's a department or division of the Department of Human Services. So that might be a good place to start.
So for this question and for the future that we anticipate, how do we want to grease this? We show this worked pretty good, I think, a screen share, and then the committee says, yes, let's ask that. And then
That's fine.
What would you like me to do? Send these 3 questions to Morgan and Katie and have them fan it out to OHA and for DHS? Does that make sense? Is that the way to do
That's
it?
the best way to do it, Morgan. I guess I want to make sure we're all good on the questions first as a committee. Anybody have opinions, concerns, questions on these questions? I guess I would look to John, Bethany, Jeff, since I don't believe you were involved in devising these questions.
So I will actually,
Okay.
I think, work with Richard on adding the information we talked about. If that's reasonable.
Yeah.
And then we'll send it to Morgan and Katie, and they'll send it on. Okay, thank you very much. And thank
Okay
you
with
committee,
that.
for approving that.
Great. Done, check. I did have a couple questions, or just maybe one question, and this is something that maybe John can help me remember from the task force. But I believe our final recommendations did not include Indian Health Service or the VA. So my question is, and I know you had like the VA taken out for part of it, Charlie, on one of those charts. Is that up to us to decide as a finance and revenue committee whether we're going to include, or is that a board decision? Morgan, do you know? I mean, what would you say? I'm just not clear on that decision point.
Can you ask that question again? Sorry.
I believe our task force, and John can correct me if I'm wrong, I don't think we included the VA or the Indian Health Services in our estimates. We just set those aside. I don't know if that's something we're revisiting as a finance and revenue committee, if that's something we can even decide, or is that a, you know, does that go up to the board? Is it just like a recommendation of ours, whether we include those two particular departments or not? I'm just trying to figure out the decision-making process here.
Yeah. Do you want John to take a?
Yeah, John, please, if I've said something wrong, correct me.
Well, my sense was in both of these cases, the task force felt that these involved populations who had special relationships with federal government around health issues that were best, you know, respected and not assumed to be something that a single payer should actually be directly involved in. You know, the negotiation between the Department of Interior and the tribes around the Indian Health Service. And I think that's what happens. The Department of Interior does that negotiation you know, is really different and special, and just realize that the tribes are, you know, autonomous. They're countries. They really have and deserve special rights and privileges. And you know, I think before you assert yourself when it comes to especially funding involving the tribes, it's best to you know, relate to the tribes themselves. And then the VA is, you know, I think that's a special relationship given the exposure and sacrifice that veterans have made, that I think the task force just felt was best. We had plenty of other things to do than get involved in that one.
Yeah, okay, good. I'm glad I remembered it that way, and it totally makes sense to me. But I wonder then if, as we're working on expenditures, we pull that information out completely. Charlie?
But I would suggest we don't pull it out completely just for comparison's sake. I mean, we can be pretty sure that it's not going to be included as part of it, but you might as well just leave that line item in there. I did pull out the VA from my estimated personal health care expenditures just because that I wanted to be a slightly different, have a different meaning, but I think we want the line item in there. But just note that, yes, indeed, what John said is all true. And also I would add that even the super waivers that are being considered, this like the state-based Universal Healthcare Act, submitted by either Rokana or Markey, do not include a waiver for either the VA or the Indian Health Services, and appropriately is so.
Okay.
But the plan that we want would cover those who are also covered by the VA and the Indian Health Services if they wanted to partake in it. So I think we need to make sure that at least that would be what I would want the plan to do, to say, you know, if you don't go to the VA, but you need some health care elsewhere, go for it, and you're covered by this plan. So I'll stop there.
Okay, thanks, Charlie. So what do you view as the next steps for health expenditures discussions? And I'm opening it up to the whole committee, besides asking those specific questions to OHA and DHS. And you can start, Charlie, since you've been.
Yeah, I'll start.
Well,
So I intend to keep working on this and adding and sharing it with Cheryl and Morgan and eventually, I guess, the rest of the committee as I make progress on it. I've got good progress on a couple of the lines already, and I'm going through the hardest ones are going to and the most important and hardest ones are going to be out-of-pocket expenditures and private insurance, because the data is much less complete, and you have to make a lot of estimates and assumptions to get there. But with enough double checking, I think we can do a pretty decent job of that.
Okay.
But the reason they're the most important is because that's if we actually do the single payer system that a lot of us are thinking about. That's the money most of the money that needs to be replaced. So.
Okay, thanks, Charlie. Richard.
I would say that one thing I'd be interested in doing is looking at that spreadsheet and seeing which of those rows come over into the column of being included in the single payer plan, and just being clear on that. And some might need a breakdown like that out of pocket. If that's out of pocket, that's paying for custodial care for either in-home care or institutional care in a custodial setting. We probably want to break that out and say, that's not going to be part of funding that we need to do. Some will be big money, some will be smaller money, but I think we need to keep bringing in front of the committee to talk about which of those come over into the column that we're going to be funding with single payer.
Okay, yeah, that makes sense. Okay, thanks, Richard. Thanks for your extra work too. Anybody else have thoughts about the next steps for health expenditures? And this would be, again, we're saving time at each meeting, so this would be on the 21st that we would have some time on the agenda. And it's that way Morgan and I can kind of plan how much time we need to. John?
Well, I think as we move along here, and as we've discussed in the principles, and to some degree in some of the discussion around expenses, it will be very important to figure out, as you look, for example, at employer funding or private expenditures on health. How much of that is for administration, and also how much of that comes from an employee versus an employer. And I think that will be very difficult to do, but it will be very important, because every administrative dollar, I think we have a potential to someday not have that expense. And every individual dollar that's currently being contributed now will be important to be able to communicate to Oregon residents. This is an estimate of what you're paying now. In the new world, you will pay it as whether we call it a premium or a tax, but you're paying it now. You just may not be aware of it. You're not looking at your check stub.
Right. Yep.
Not telling you, but you're paying it. So those categories, I think, are going to really be key.
Yes, definitely. I agree. Bethany or Jeff, do you have any comments to add about next steps for health expenditures so we can stay on track here?
Nothing to add.
Okay, thanks, Jeff. Okay, so with that, I think we're on to meeting reflections. This might be a good time for me to convey a couple messages from board members, and resulting in questions for you. I also want to mention something about the RFP process for the consultants that we're going to be needing to use as soon as possible. So I'll start with a message from the board, and maybe some of you have listened into our last board meeting, but we all reported on the activities of our committees, where we are at. And one suggestion by the board was that we use the year 2028 for estimates of revenue, because 2026 is too soon. So so that was number one. So as we get into more of the revenue discussion, to use that as the comparison year. Does that make sense? Do you guys agree with that? Okay, Charlie?
So I think there's a couple of things going on. I think in our principles, I'm not sure if this is in there, but I thought it might be that we wanted to start with revenue for a year that we can compare. So pretend, for example, that in 2023, this system was there. What would our revenue look like, and how would that compare to necessary expenditures? And then we would project to a later year. And I would suggest that 2028 is not an appropriate later year. It should be 2030. And my reasoning for that is that, I mean, it's going to be harder to project that much further out, but if things go well, and our recommendations, come out in the end of 2026, and it gets considered by the 2027 legislature, I think the most reasonable expectation is that it would be on the 2028 ballot, they wouldn't have a special election for it, and they wouldn't put it on and it would probably be the general election ballot, not the primary election. That means that if things go well, we might have voter approval of this system in November of 2028. Well, that's not going to give you enough time to start it in 2029 even.
Right.
And so I think 2030 is a better year. That would be my suggestion.
I can take that back. And yes, and that's exactly what I meant, was the projected revenue and costs. So yes. Does anyone else have an opinion about that? About the year that we're using to project the revenue needed? Okay, well, I'll take that back, as I said. The other information that I wanted to share is that I asked my operations committee colleague, Bruce Goldberg, he's the chair of that committee, about meeting together about the waivers, and so that we wouldn't be duplicating efforts or working at cross purposes. He mentioned to me that the waivers discussion for operations committee is in February. And so the question I have for you is, do you think it makes sense for us to join as we can to observe their meeting? Or do you think we should try for a joint meeting of our committees to discuss? Or is this like just a separate meeting that we have to discuss the waivers? So those are my questions. How do you think that makes sense? Charlie?
I think if we're going to be there, it's going to be much more useful for us if we can join in the discussion and ask questions. So I think being observers wouldn't be sufficient. But then if we have a joint committee, in order to proceed, does it need to have a quorum of both committees there? And so would that hinder it? I mean, is there a way that committee members can say if it's their committee, but committee members from finance and revenue can be there as in some capacity in which they could ask questions without needing to be a quorum?
I think that's a good question that I don't know the answer to, and I wonder if Morgan does. So I'll pitch it to you.
So I think that this is going to get us into some public meetings conundrum. So if there are two members of the finance and revenue that maybe you designate to attend that meeting and bring information back. That may be a way to assure there isn't a quorum in a unnoticed meeting of finance and revenue. Because I think if there are more than 2 or 3, you can run the risk of, talking to somebody and then having it be an intermediary.
Right.
And I think that it would be a request of the chair and vice chair of the operations committee about the status if it wasn't a joint meeting, which I don't think that I think Cheryl's spoken to Bruce that there's interest in having participation from finance and revenue. But those are kind of my initial thoughts. If folks were able to attend, I think the easiest thing is to have both committees there and have a joint meeting and have it noticed as a joint meeting. But we would need to make sure there was a quorum of the finance and revenue, which is 5 members to do that.
So I probably should go back to Bruce and talk about these options. I did send an email with these options and I haven't heard back from him yet, but I can talk we have a board meeting next week, so I can talk to him about it. Jeff?
At the risk of oversimplifying, the waiver question to me seems very straightforward. If we get a waiver, we can do this. If we don't get a waiver, we can't.
I think it was, and I'm sorry, I don't have all the details. Maybe some of you do. I think it was the fact that both of our committees are considering certain aspects of waivers, and it would be helpful if we talk together about them. I just don't remember what those details are at the moment. Maybe someone else does.
Are we talking about the same waivers? I mean, we have we have the 1115 waivers to include new climate and nutrition and housing. Or are we talking about the waiver, meaning to allow Medicare and Medicaid to flow into the state?
The second one, yeah, the second one, yeah. John?
Yeah, just a couple of items. One is really to return to the timing issue. We have a waiver. It expires, I think, maybe in 28, 29. Certainly the state will want to continue that process. So likely, I think it would be the 27 legislature that might be engaged in, what the next waiver would look like. So anyway, figuring out the timing, I think would be informative for that for me. The other statement, I don't really think this is an issue of can you get a waiver or can you not get a waiver? In my mind is, can you get an extraordinary waiver? Because the degree we could get an extraordinary waiver would significantly reduce the need for revenue from other sources, both on the Medicare and Medicaid side. And there is a history of, if states happen to be in the right place at the right time, of getting extraordinary waivers. It's happened in the past. And the degree to which we believe that would be possible is relevant to the discussions we're going to have about how much revenue needs to be raised, and what ideas really would generate an extraordinary waiver. So that's where I'm at.
Okay. Well, I'll talk with Bruce a little bit more about what we would, the particular discussion topics that we would want to meet together about. And so I'm a little bit clearer, because it seemed to me the last time we met, there was some overlap, and it would be helpful to meet with the operations committee, but I just don't remember the specifics right now. Richard?
John, which waiver did you say was expiring in 28 or 29?
The one we currently have.
1115, probably you're talking about.
Okay, so now we're getting back to the 1115 waiver.
Right,
I'm getting
yeah.
confused when you say waiver. Which waivers are we talking about?
Yeah, there's so many.
But clearly, I got the extraordinary waiver that allows us to capture Medicare and
Right.
Medicaid money, but let's make sure we identified if we're talking about the 1115 or 1905 waivers that we do something.
Well, and actually, that's a good point, because we do have multiple waivers. You know, we have a waiver of some sort that enabled the bridge plan to be created. And, you know, I'm not sure what the timing is for all of those waivers, when they expire, and when OHA, as a result, would start to try and figure out what are they going to do to replace them, et cetera.
A related topic is the state-based Universal Health Care Act, and I'm really interested to know more about that. I'd heard about it and I'd frankly forgotten about that. And I know that was mentioned in a written testimony today, and I think that might be a subtopic we could discuss with Operations Committee as well, in my opinion. Okay, so the next thing I wanted to mention was that you may know that we have a committee to review RFPs or RFP proposals. Applications, that's what I'm trying to think of. And it's a small committee with the board chair and vice chair, I believe, and staff and myself, and Charlie volunteered, so you're on that committee. It turns out that the meetings that have been scheduled, I cannot attend, so I'm wondering if someone else from this committee would like to join that group to review the proposals. Richard? Okay, would that be okay, Morgan, if Richard takes my place? Because I mean, I just can't attend. So, okay. And would someone be able to forward those invites? There are 2 meetings, I believe.
Yep, and just to say, because we're trying to move so quickly, we can't move the meetings, which is why we're losing Cheryl. But Richard, I will forward those to you, and let me know if you can attend.
Thank you so much, Richard. I really appreciate it. And just if, you know, you guys can keep me in the loop, or we can, I don't know exactly what the timing is, Morgan, but would it make sense to have an update on the 21st agenda or is that too soon? I can't remember.
We won't have anything to report on the
Okay.
21st.
So just February then.
Yep.
Okay, got it. Charlie?
I was just wondering if it's appropriate to ask for what sort of this process, or is sort of nothing happening until that first meeting, or what's going on with that?
It is posted and people are able to find that on Oregon Buys, and there's nothing. We sent it out, the procurement folks sent it out, and it's available, and we hope that there are potential contractors who are going to be responding to that, but there's nothing else happening.
Okay, so with that, now I want to get to any reflections you'll have on the meeting today, and also get to specific agenda topics for the next meeting. I think I'll ask Morgan first to remind us of the revenue topics that will be on the agenda at the 21st, because I honestly don't remember at this moment.
Yeah, sure, of course. So in our timeline and plan, the next kind of formal topic is structural challenges, which we're looking to have some information about ERISA, just to make sure the committee is aware of ERISA, and to make sure that as you're thinking about designing a revenue structure, you do everything you can to avoid an ERISA challenge. And then we have invited HMA to come and bring information, kind of like they did for revenue sources, about administration from Optimus, and provide that to the committee, so that you can look at that for kind of assumptions around administrative costs. And then, of course, we'll have health expenditures that you've already talked about, and I'm looking in conversations with LRO to come back to the January 21st meeting to follow up to their last conversation about revenue.
Okay, that sounds great. Any other suggestions or just reflections about today's meeting, Charlie?
So I was wondering if any progress has been made on getting legal advice related to the income tax, whether there is a possibility of structuring a tax based upon income that's not subject to the kickers.
Great question. I've been working with our DOJ attorney, Jake Gill, who is primarily there to support the board. He's not a tax and finance guy, so he's trying to identify somebody at DOJ for us to work with on that question. And we don't have anybody yet, but it's in the works.
Thank you.
Thanks, Morgan. Jeff?
Thank you, and good meeting today. And this is a suggestion for looking forward to the end game when the final report is produced, which I anticipate will be lengthy and detailed and complete. But it should, my suggestion is it needs to have a one-page cover page that identifies the key assumptions. It identifies the various revenue sources with the estimated range of dollars from the sources, the estimated cost for OPEB coverage, which is where we're settling on, times 4.2 million Oregonians, the net, and then the different ways of funding that differential that's needed by the different types of revenue available. Just a one-page summary to go attached with the I'm saying 200 pages, but whatever it is in terms of the final document. And I think we should keep that in mind as going forward as we get to the end game with the final production of our report.
Sounds good. I'm all for short executive summaries. I agree with you.
Thank
John?
you.
Yeah, it doesn't have to be at the next meeting, but at a future meeting, I think it would be good to have a Medicare specific discussion. I mean, Medicare is individual insurance that essentially all of us have contributed to over a working lifetime through a payroll tax. And that when we turn a certain age or become disabled, we become eligible for it. And it has all these different parts, and those parts are funded differently. And oftentimes those parts are funded by additional contributions, as in Part B contributions, etc. You know, the federal government has, I think, stirred up a hornet's nest by creating Medicare Advantage. So creating another stream, if you will, of potential revenue from Medicare, and we need to understand that more, even though it's a mess. But I think it would be good to have us start understanding Medicare and how it differs from the other two sources, and you know, what that might mean in terms of revenue options. And you know, reminding when we talk about the progressive approach to taxation, the age segment that has the most wealth in the country are folks over 65. So there's a lot of tricky and challenging issues when it comes to Medicare.
No kidding. I think that's a great suggestion. Thanks, John. I agree too. Richard?
So John, who would you like to see present that, and what specifically would you like to see presented at that when we discuss Medicare? I mean, is this something that we could do internally? Do we need an outside expert, or just need attention, or what are you thinking?
I'd have to think about it. I don't know off the top of my head. I would guess an outside person. But I'd have to think about it, Richard.
Okay.
Good follow-up question, because it seems to me it's so complicated, we'd at least need an expert for part of that discussion, outside expert. Any other thoughts before we move to public comment? Charlie?
Relating to Medicare, I'm hoping to, well, I've started delving into that a little bit, and I will include information to the extent possible about funding sources for federal Medicaid. And since most of that money that comes into Oregon comes directly from the feds, it's essentially the same funding sources at the same percentages because they don't designate this part for this state and this part for another state. So I will include that information in the current expenditures stuff that I'm doing for Medicare.
Great, thanks, Charlie. So with that, I want to acknowledge the 3 thoughtful comments we received in writing, and hopefully you all have read those. I know they were attached and part of the meeting materials. And now we have, I believe, 1 person who will provide a verbal comment today. Is that still correct, Morgan?
Yes.
Okay, so Katie.
Wonderful. So yeah, we have Lee Mercer signed up to share public comments. So Lee, if you're able to connect your camera and audio, you can take it away when you're ready. And please remember to keep your comments to 2 minutes.
Okay, I'm here, and thank you for the work you're doing. I was formerly, at one point, I was the board chair of Healthcare for All Oregon, and for a number of years, I was an organizer for Main Street Alliance of Oregon that reached out to business owners all over the state of, small business owners all over the state of Oregon, and got them engaged on progressive political issues and legislative work. And Main Street Alliance has been an ally of Healthcare for All in this work for a number of years, and believes very much also in getting to a universal healthcare system. My testimony is really, part of it is almost plagiarism from a letter written. Charlie Swanson and I and several other people did the Merkley meeting that was described in this letter when we were talking to him about the Senate, getting him on board on the Senate version of the state-based Universal Health Care Act. And he did get on board after that meeting, so I think we can take credit for it. But I think the main thing is, I mean, reading the state-based Universal Health Care Act, I'm glad there are people like you smart enough to read it, because I can't understand it. But it is moving us toward the ability to have the waivers we need to do what we need to do. And I'm encouraging you all as individuals and as citizens to reach out to Congress and get them to pass this bill, get this thing in the works for all the states that are lining up. And I think we're first in line to get to universal health care. So again, thanks for your Herculean work and your efforts at a very quixotic quest to get to where we need to be in this country for healthcare. So thank you.
Thank you so much, Lee. I really appreciate the reminder of this federal effort. So that's great. Richard?
Can I ask Lee a question about the Main Street Alliance?
I don't know. Morgan, is that okay to ask questions of people who public comment?
Lee, thanks for your testimony today. One thing that's really, really, really important is to get employers on board. I mean, we have many, many different factions to get on board. And it seems to me that this is a huge win for employers in general, but love any input you have or will have in the future about messages to make to employers to get them to support something that I think will make it more competitive for them in their own environment and should be favorable to them. Over.
Yeah, and again, as we all know, the most difficult, I mean, logically, the most difficult people to get on board are the small businesses, and these are the people in Main Street Alliance, and they're the ones that's actually going to cost more than what they're doing now, because most of them don't have health insurance for their employees. So that's a problem we have to deal with. But Main Street Alliance, I mean, to be completely frank, Main Street Alliance is part of a national group that used to be based in Seattle, and we do have hundreds of people on lists, but we're less active now. We don't have a current budget due to the current condition of Main Street Alliance nationally. They're starting to work with some other national groups on other policy issues, still support universal health care, childcare, and other stuff that we'd like to see worked on. We don't have the ability and the capital as much as we did 5 years ago to bring people from all over, but we have lists and we have people that will be stepping up to testify for this work when we get there.
Lee. With that, is there anything else for the good of the order before we adjourn? Okay, well, we'll see you on the 21st. And thank you for all your work and dedication to the objectives of this committee. Appreciate it. Have a good weekend.
Bye-bye.
Bye.
Be well.